Hello, Betty. Good night from Turkey to Denmark. So happy to see you again.
Murat. Good to see you here today.
Betty, sometimes I lose my Zoom links. Just before start, I just reminded myself. Sorry not to being able to attend to the last EEG, but I really miss all of our patients. Thanks to them, tonight they arrived here to listen us and hope become a voice of the ESGO science in their local countries. And I hope we again see each other very soon in face-to-face in the next patient seminar. But tonight we have three speakers and very important topic in prevention of ovarian cancer. You know how big and hard cancer is ovarian cancer, how to fight with it, but we have actually preventive measures. Actually, we can prevent millions of ladies to become an ovarian cancer. Tonight, we will talk about the genetic screenings, medical prevention in the young girls, and finally, surgical prophylaxis. So it's my pleasure to have three important speakers, Ranjit, Claudia, and Eric, the most prominent three European experts in this science. Bertie, let me give the microphone to you and welcome all of our friends once again. Bertie?
Yes. Welcome, everybody. As you see here, we are starting with Ranjit Manchanda, and we're listening to personalized and risk-reducing surgical management in women at increased risk of ovarian cancer. And then we will learn about oral contraceptives by Claudia Marchetti and surgical prophylaxis by Dr. Leblanc. So it's a very, very interesting session for all of us. And I'm very pleased that you're here listening to it today. And I also want to tell you that I have written a vocabulary list that will be shared with you, because when I read some of the presentations here, I realized that there might be many new words. So I hope you will take a look at that when it is shared with you. Yes, and then I would like to give the microphone to Dr. Ranjit Manchanda for the first presentation.
Thank you. Good evening. It's a pleasure and a privilege to be with all of you. Delighted to be able to talk to you about personalizing risk-reducing surgical management in women at increased risk of ovarian cancer, something I feel quite passionately about. Just starting with some disclosures on research funding, etc., and also acknowledgement of various charities, patient support groups, community groups that we work with in this work. We all know ovarian cancer is a horrible disease. There are several challenges. Women present at late stage or advanced stages. There's poor survival with ovarian cancer. Regrettably, most people who get it will die from it eventually. We don't have a well-established screening strategy. And there's an increasing number of cancer cases. And if you look at data from GloboCan, then the number of cases and deaths are predicted to increase worldwide or in the UK or across Europe quite significantly over the next 20 years. Oops. Fine. However, we can prevent it. And as you will hear today, there are very effective strategies to prevent ovarian cancer. So our strategy for preventing ovarian cancer starts at better identifying those who are at increased risk. So there are a couple of ways to do that, and we'll talk about that. So it's important to identify people who are at risk, do better prevention. There's a lot of surgical prevention strategies we can use, and that will lead to fewer cancers and fewer deaths amongst people. Hopefully, most people have heard of BRCA1 and BRCA2, which were the traditional ovarian cancer and breast cancer genes associated with an increased risk of ovarian cancer. But additionally, there's another panel of genes which includes these genes listed here on the screen, PALB2, RAD51C, 51D, BRIP1, and the Lynch syndrome genes, which are also associated with an increased risk of ovarian cancer. And there's also an opportunity to use various genetic factors and your other risk factors to give a personalized risk of ovary cancer. So how can we identify people at increased risk? We can test everybody for cancer genes. That's called population testing. That's quite a paradigm-changing approach because it's not what usually happens. We need to do more testing at cancer diagnosis. That is happening a lot, and I'll talk about that. There's more need to increase awareness and access, and all of you are really important in increasing awareness. And we need newer delivery models to deliver genetic testing, because if you're going to do more gene testing, we need to do it in a different way because the health systems can't cope with it then. It's important to be able to personalize surgical prevention, and we need to consider the woman's age, what cancer gene she has, what the risk is, does she have children, the issue of menopause, whether she's pre or post-menopausal, and my colleague Eric will talk more about strategies in that. And also whether she's had, for example, breast cancer or other cancers in the family. All these things are known to be associated with decisions women make. There's the option of removing both tubes and ovaries, or a new two-step operation where you remove the tubes first and then the ovaries. There's the broadening of access to surgical prevention. A hysterectomy with the tubes and ovaries is only done in women with Lynch syndrome, because they are also at increased risk of womb cancer. These are the genes I listed out, and there's the risks of ovary cancer. The average risk of ovarian cancer in the population is between 1.3 to 2%. So 1 in 50 women get ovary cancer in their lifetime, but the risk is increased with one of these genes. And 20% of ovarian cancers are caused by one of these genes. But more than 95% of women who carry these genes don't know about it because they've not been identified. The traditional way to pick up women at risk has been by using family history. And Angelina Jolie, this is her family. She has a grandmother and mother who had ovarian cancer, and an aunt who's also had cancer, breast and ovarian cancer. And she was found to be a BRCA1 carrier, but most people aren't like this. They don't have the best access to healthcare. We know there's huge underutilization of gene testing in health systems. We know that even if you use this family history, you miss half the people or half the carriers at risk. If you look at big population level studies, where you test everybody in the population, then up to 80% of carriers, some studies suggest, are missed using this family history approach. And this works better in white women rather than Black or Asian women. So depending on your ethnic or racial origin, these criteria may work less well or better. So that it sort of exacerbates disparities. So ask yourself, would you use a diagnostic test or a test which is going to miss 50 to 80% of people with a problem or disease? That's what we're doing when we're using family history. So we need to move away from that. And why do we need to wait for people to get cancer to identify people in order to prevent cancer? I think that's wrong. And that's, again, something we need to move away from. So I would say that, diagnosing a BRCA carrier or a gene carrier after a cancer diagnosis is really a failure of cancer prevention today. So how can we pick up more people at risk? We spoke about doing more of testing at cancer diagnosis, or just offering everybody testing, and I'm going to cover a bit of our work around that. So who do we test at cancer diagnosis for? Today, everybody with ovarian cancer, for example, womb cancer and bowel cancer, should be able to access gene testing or go down a pathway which offers access to gene testing. And that's available in clinical practice. What about breast cancer? Well, why don't test everybody with breast cancer, or men with prostate cancer or pancreatic cancer? I think that's also going to be a direction of travel. But testing for these three cancers, ovary, womb, and bowel, is now there in most guidelines. This is a study we did with 2,400 ovarian cancer cases from the US and UK, and we find that about 1 in 6 women have a BRCA gene. But if you test for the other genes, you pick up another 2 to 4% of people who are at increased risk of ovarian cancer. And this is an economic analysis for the health system, which shows that panel testing is very cost effective compared to just family history-based BRCA testing, which used to be done, both for US and UK health systems. And therefore, there is no reason why we should not be moving to panel testing from just doing BRCA testing in women with high-grade ovarian cancer. So we should no longer just doing BRCA. We should be testing for the other cancer genes too. This has come into some guidelines, but not yet all guidelines. And this is a paper in press and should be out, I hope, in the next 1, 2, 3 weeks. So unselected panel testing, the testing for multiple ovarian cancer genes, is cost-effective and should be undertaken. We don't find the cost of PARP inhibitors at the moment is quite high and needs to be reduced by about 30 to 40%. What about breast cancer testing? In 2019, we published this and we showed that yes, health systems, it would be cost effective if everybody with breast cancer was tested. And we found that you prevent thousands more cancers because if you test for BRCA and PALB2, these women are also at increased risk of ovarian cancer. And you can prevent both breast and ovarian cancers in the future. There is a study which has been running in the UK called BRCA Direct, where all women, over 1,000 women have been offered testing for breast cancer and using what's called a direct or to patient approach. That's saliva-based testing, just like you get a tube in and you spit into it, and they started giving a blood test. You can take DNA from the saliva and do the gene test. And that has shown good outcomes. It was a non-inferiority study. This has led to a pilot clinical implementation project, which is now running across London, where across, I think it's 14 hospitals. All women with breast cancer over the next 18 months are being offered gene testing as a pilot study. And this is being led by the ICR team, Claire Turnbull and colleagues. And our team at Queen Mary's is doing the evaluation of this program. The other thing to point out is this is the new NICE guideline, which has come out. It was published last week. This is a really important document. Would encourage everybody to have a look at it. It's backed by a huge evidence review and 2.5 years work by a very strong committee of stakeholders. And it even recommends, there's a lot of new guidance in it, and that genetic testing should also be offered to first and second degree relatives of women with ovarian cancer, so we can pick up more people at risk and offer them screening and prevention. So if we are going to do so much gene testing or more gene testing, we need new approaches to do this. And the direct to patient approach is a favorable way of looking at it, or one option to scale up. You can offer the genetic testing information on a web app or electronic media. You can make a decision to test on the app. You can do testing at home using a saliva sample. You can get the results by post and email. You're available, a counselor is available to talk to you over the phone or virtually on a video call. And the whole process can be supported by a counselor who's virtual. And this is a strategy we are implementing now in our trials. And we have the DETECT2 trial, which is starting, I hope, in the next couple of weeks, where all people with ovary, bowel, or womb cancers will be divided into one of two arms. That's two groups. That's standard mainstreaming or the cancer clinician doing the counseling and testing versus directly offering the testing at home using a web interface and a web app and a more digital pathway. And this trial will run over the next couple of years or so across multiple UK centers to look at differences in outcomes. I'm coming to testing in the Jewish population. I seem to have lost a slide. Just to say, we've done a lot of work about testing in the population testing in the Jewish population. Whenever Jewish individuals have a much higher chance of carrying a BRCA gene mutation, I find that in about 1 in 40 individuals versus 1 in 200 to 250 in the general population. And if we summarize the evidence, then we find that about 60% of people would be missed if you didn't do population testing. That's offer testing to everybody. It's feasible, acceptable, reduces anxiety. And when you do the economic analysis, it saves lives and money both, so cost and money. So there's a strong body of evidence, and there are other trials also run in Israel by my colleague Birthe Lemley, also studies in Australia and Canada and in the US, which show similar sorts of things, that population BRCA testing in the Jewish population is feasible, acceptable, as high satisfaction, can be delivered at a population community level, is not causing harm, and is cost saving or cost effective. So this has led to paradigm or change, and in the UK, or at the end of January, the NHS England cancer program team launched the Jewish BRCA testing program, where anybody of Jewish origin can directly register and have a BRCA1 and BRCA2 gene test. So this was a policy change and a huge thing, paradigm changing strategy for both predicting risk, identifying people at risk, and offering screening and prevention. So this is the website you can that people can log on to. You can self-register, put in your details, and you can access counseling through a helpline, and you will be sent a consent form and a kit, saliva kit in the post, and you send it back and you get a result. This is just a full chart way saying you register, you receive the information, you consent, return the saliva kit, you're offered counseling, and then family members who are positive can also undergo testing or cascade testing through the program, and you get referred to genetic services, and your GP is informed of the results, and you can then access the NHS screening programs, for example, for breast cancer or risk management strategies by getting referred to clinicians like gynecologists for ovarian cancer prevention, etc. Moving away from the Jewish population, testing in the general population, we found that this is cost effective for USA and UK health systems, and you can prevent thousands more cancers. So if you test for breast and ovary cancer genes in the general population, we also showed that even if you do this across multiple health systems, for example, BRCA testing, then in upper and high income countries, so UK, USA, Netherlands, China, Brazil, this would be cost effective and you prevent thousands more cancers. We also recently showed that it'd be cost effective preventing many, many more cancers in women in the Canadian population. And this is a paper being submitted as yet for publication. This is the work done with the British Columbia team, the University of British Columbia team. This is a pilot study we did showing that there's huge acceptability and it was feasible to offer ovarian cancer personalized risk estimation in a general population and test them for cancer genes. We were published this a few years ago, going through primary care, and there was huge appetite for this, 85% uptake. You could offer information on a web-based decision aid and counseling support through a helpline. And there were good outcomes. This was published a few years ago. This, of course, has led to this new study called Protect-C. This is moving on from the Jewish population testing work. This has set the scene nicely for general population level testing. And we hope towards the latter half of the year, maybe towards the autumn, we will start this study. We are working on it at the moment, where we will offer women across the UK testing for a panel of cancer genes, a personalized ovarian and breast cancer risk estimation, and you'd then be offered referral for screening and prevention, etc., advised through our health system, and be able to access the national cancer screening programs for high-risk people, as well as see clinicians who can offer risk-reducing medical or surgical preventive management. We're going to look at patient experience, the economics of it, a whole range of outcomes. This will take a few years to do, but hopefully we'll fill a lot of knowledge gaps, which will allow us to make a decision on moving towards population testing for cancer genes at a more general population level, away from high-risk populations. So we've spoken a bit about increased testing and identification, and just a little bit about broadening access before I stop. So you see the new NICE guidelines supports the concept of personalizing surgical prevention and broadening access for it. I've mentioned this earlier, that the different surgical options, and it needs to be individualized or personalized depending on the age, gene, cancer risk, children, menopause, fertility, patient's wishes, etc. We know that this is a dynamic, difficult process. Decision-making can change with time. I think people are best managed in a multidisciplinary team. And we know women need additional support and sometimes need to see specialists like menopause specialists or fertility specialists or psychologists. And decision-making changes with time, but as time goes by, people may make a decision to undergo surgical prevention. So what should be the risk threshold for surgical prevention? We've shown it should be about 5% lifetime risk, and that 4 to 5% lifetime risk saves 7 to 10 years of a woman's life. And therefore that makes it an appropriate intervention. And this is cost effective for a health system to change policy in this regard. This was introduced in RCOG and UK Cancer Genetic Group's guidelines earlier, and now a week ago, this has also been introduced in the NICE guideline, where we recommend surgical prevention at over a 5% lifetime risk. So we know 60% of ovarian cancer cases occur in about a 5% risk threshold. So that means 6 in 10 women who get ovary cancer may have a 5% or greater risk of ovary cancer. And therefore, if we can identify these women, we could potentially prevent cancer in them. There are more complex ways using AI algorithms to try and predict personalized ovarian cancer risk, which uses a lot of information like your age, your hormonal contraception, family history, number of children, etc., and also something called a polygenic risk score. And they are now validated algorithms which are beginning to emerge, and therefore we can use them to identify people, to give a personalized risk prediction to pick up people at higher risk. And that's sort of what we're going to do in the PROTECT-C study. With respect to the various other ovarian cancer genes, this is an analysis we've done with the NICE team. We did for NICE, and it's just published in JAMA Network Open. And we've shown how many cancers you could prevent, as well as what ages you should be offering surgical prevention. And if 1,000 women had surgery with the various different genes, these are the number of cases of ovarian cancer you could prevent, ranging from 390 to 55, depending what the initial risk was. And really, this has a lot of modeling in it, but the simple take-home message is that for BRCA1, mastectomy can be considered at 30, and removal of tubes in ovaries at 35. BRCA2 is removal of tubes in ovaries is 35 to 40. PALB2, it's 45. RAD51Z, 51D, it's 45, and BRIP1, it's 45. And that's really what you find in our new NICE guideline also, where recommended ages for surgical prevention have been provided for different, depending on what cancer gene you carry. I do want to flag up, because this is something new in the guideline, that surveillance for ovarian cancer as an interim risk management strategy has been supported for those who are delaying decision-making. But if it's done, it needs to be a 4-monthly CA1 to 5 analyzed by a complex longitudinal algorithm managed through a high-risk MDT with an annual review of decision. And this is our MDT setup and how we manage our patients. So we would have CNSs, menopause, a specialist psychologist linked into genetic services, and then breast oncology and colorectal and PGD teams. And we find better compliance and higher patient satisfaction using this. Again, this is a nice flow chart in the NICE guideline, where if you're over 5% risk, you can have surgical prevention, and you need to be managed through an MDT setup. And this recommendation has just come in also within the new NICE guideline. So to summarize, I think we're moving to an era of better personalized risk prediction and targeted screening and prevention. There's a lot more we can do to pick up people who are at risk and prevent cancers in them. We need to move towards panel testing at cancer diagnosis for various solid tumors. We need to, more relax our testing criteria, and that's happening. You can see in various guidelines. The technology we have, we can test at large scale and large populations and with high throughput. And the costs are falling to be able to enable us to do this. But we need to develop new context-specific deliverability models which can be scaled up to implement these strategies. A direct-to-patient approach holds promise and is being investigated in research studies. BRCA testing in the Jewish population is safe, feasible, acceptable, and has been implemented. It's now available in the UK. It's also available to all Jewish individuals in Israel. Population testing in the general population needs a bit more research, and implementation studies are running, for example, in the UK. But it has been shown to be feasible, acceptable, potentially cost-effective, but the implementation studies will need to deliver the long-term research outcomes. The removal of tubes and ovaries is the most effective strategy to prevent ovarian cancer. It should be offered at more than 4 to 5% lifetime ovarian cancer risk. It needs to be personalized, depending on circumstances, gene, age, risk, fertility, etc. I'm sure the issue of a protocol and the importance of a CFIM protocol on HRT will be covered later by Eric. So I just want to highlight that, but I'll stop there. Just a big thank you. This is our predicted trial, which is also an early self-inject trial, and our collaborators meetings. So we work closely with colleagues across the UK. And this is my team. A big thank you to them. They really do a lot of the hard work. So I'm running a lot of the trials we run in the team. And again, a big thank you to the NICE team, who we've been working with over the last 2.5 years to publish the guideline, and all the stakeholders involved. These are colleagues on the committee, but also there's a huge team at NICE with the systematic reviewers and guideline leads, etc., who support this work. Thank you.
That was really very impressive, Ranjit. Thanks a lot. And it's so good to hear how much is going on now and how far you are in the UK. And I don't think we are that far in Denmark, but it's really impressive to hear. I have one question for you, though.
Yes.
I'm HRD negative, and I'm an ovarian cancer patient. Can anything be done to check for ovarian cancer in such a case? I was thinking about ctDNA. Could that go far enough so that we in the blood can detect dead cells of ovarian cancer, and in that way, because the problem here with ovarian cancer patients is that most of us are diagnosed in stage 3 or stage 4, and many of us die from the disease. So my question is, of course, is that far out in the future, or how do you see that?
That's a really good question, Birthe. So let me tackle it in 2 ways, because you raised the important issue of people who are, say, BRCA negative or HRD and HRD positive. One, if you extend the panel, the testing where you test for other HRD genes, you might pick up people at risk, and therefore you can prevent cancers in other members in the family, or even if you test the population, you'd pick up people with other HRD genes other than BRCA. Number 2, you might get people who are even HRD negative, but maybe at increased risk. And that's what we are trying to do, and pick those people up through these AI algorithms I mentioned on one of the slides. So we have now validated algorithms where you can use your personal history, your profile, so number of children, your weight, your height, your age, and what's called a SNP score. So it's like small changes in the genes, but not something that's very common. So people may carry 30, 40 SNPs, but put them together, you could get a significant jump in your risk. And when you add that to other factors through a complicated mathematical algorithm, you might get a risk which is above, say, 5%, which is at the threshold for prevention. So you can prevent cancers in them. So one, we can do more to prevent cancers in people who, say, are BRCA negative. So that group of people. Number 2 is the issue of screening, which you raise. Now, we know that screening, unfortunately, in the UK CTOX and even earlier the PLCO before that, did not show a benefit of saving lives. It showed we can pick up cancers early. It shows that we downstage. That means we can pick up more stage 1 and stage 2 cancers. It also shows that the surgical outcomes were better. That means more people had all their disease removed at surgery, but still we didn't more people didn't live longer. We did not save lives. So we need new screening strategies. ctDNA is being investigated in some trials. Some of the multi-cancer early detection trials use this sort of approach. There are other biomarker models, biomarkers, which can be used in a modeling approach. We have initially used, the screening trials we ran was with CA125 using ROCA, that's the risk of ovarian cancer algorithm, which is a mathematical algorithm which looks at the change in CA125 over time. We now have promise for a multi-marker algorithm, lots of new biomarkers which we want to use to try and pick up early cancer. In fact, we've just got some grant funding and a grant award to look at new biomarker modeling, which can improve previous screening strategy of ROCA, which is and more international sort of study we're trying to start. There are lots of other colleagues who are looking, and teams who are looking at other screening strategies. But I think it's more an issue of ongoing research at the general population level.
Yeah. Okay.
That will evolve over time. In high-risk women, it's different. In high-risk women who are waiting for risk-reducing surgery, the new NICE guidelines suggest that surveillance with CA1 to 5 every 4 months using a mathematical algorithm can be an interim option for them. So that's sort of where we are with screening. So I think it's a lot more work needs to be done, but I think there's a lot of promise. And I hope something will evolve in the years to come.
Okay, thank you very much. I'm just going to ask, are there any other questions in the chat?
Yeah, but there are 4 questions. Let me to quickly, but really quick answers. The first question is from our dear friend Eva Maria. Should also a patient with a rare ovarian cancer be tested with these panels? Or do you think that we have a panel that can cover the rare ovarian cancers?
Yes, we have a recommended testing for rare ovarian cancers also. It's in the NICE guideline, yes. So the relevant ovarian cancers should be tested.
Is this NICE guidelines only for UK, or do you have any European level guidelines?
NICE is, is NICE, I guess, is a UK body. So it's published and it's the UK is meant to follow it. But I know that various other colleagues and internationally and some other health systems do tend to reference and use it a lot. But it doesn't say other people shouldn't use it. So, so I think it's fully used and relied on from lots of colleagues around the world. But it is there, it's in there, it's in the guideline.
But Martina, just a quick answer. ESGO, as the Gynaecological Society, is now starting a project with Claudia, the next speaker, and Ranjit is also in the team. And we want to make an ESGO statement, and we want to announce to our members, national societies, some sorts of guidelines for genetic screening and prevention of ovarian cancer. But of course, it's not an official European level, Commission level guideline. Ranjit, also last question from Sharon. What is the cost of a panel gene testing? I mean, and can we find these tests in other than UK in different countries?
Yes, you can do them online. There are lots of companies that offer them. You'll be sure you go for the right company. So it should be an accredited test. I guess the cost of the test varies depending on who you go to. I know companies who can offer this for like, I don't know, about 300 euros or 250 euros. Also, you can get testing. BRCA 1 and 2, you can even, there was a time when Color used to offer it for even $120 or something. So there are lots of companies which offer a cheap level. I know in parts of Asia, in India, you can get it for 20,000 rupees, which is like 200 pounds. So no, so
I think they're getting cheaper day by day.
In some health systems, the cost is much higher. Some providers will charge you many hundreds of pounds, but there are providers who will charge you less and give you an accredited result. So I think
thank you, Ranjit.
A few hundred pounds, it's not a few hundred euros. It's not that expensive.
Yeah, affordable to prevent a life. And also for our patients, my message is that maybe you dismiss, but Ranjit talk about a multidisciplinary tumor board, an MDT for these genetic patients. I mean, not easy to make the test, to have the result, to comment on the results, to suggest and recommend some sort of surgeries. And I think these patients, if they are really young and if they know that they are BRCA positive, there may be some stress and anxiety. And I think these patients should not be, it's not only screening, but evaluation should be by a multidisciplinary tumor board. And covering different aspects, especially psycho-oncological aspects of the patients, right, Ranjit? I mean, that's why you have these tumor boards.
Yeah, I mean, it's not just the oncology patients whom you're testing at cancer diagnosis, but the new MDTs we are suggesting is for high-risk management. So people who are unaffected should also be managed through an MDT, which involves genetics colleagues, psychologists, menopause, fertility, people with special interest in this area. So so it's an MDT approach, as you say. Some of them may have increased anxiety. They may need, they have different needs and complex needs, and decision making is difficult. I do both, as you do, I do, and we do both, managing patients with cancer and without cancer who are high risk. And I think high risk women actually have huge needs, far greater.
Exactly.
Some of them who need to be supported along the way, and they find decision making quite complex and difficult. So I think what we have shown, and we've also published, and we find is that people who are managed through MDTs have better satisfaction, better compliance, better access to care, better HRT compliance, and clinical compliance, and seem to be happier with their care rather than those who are managed outside of specialist interest structures of MDTs.
Thank you so much, Ranjit. Birthe, I think we have answered all questions. Microphone is again with you for our next speaker.
Okay. Yes, I would like to welcome Professor Dr. Claudia Marchetti, who is going to talk about oral contraceptives, hormonal IUDs, and chemoprevention.
Yes, thank you. Thank you for the introduction. And also thank you for inviting me, because I think webinar or conference together with patients are really those in which we remember who we work for and why we do research. So it's really an important occasion for all of us. And as you suggest, my task today is to discuss with you the role of a medical prevention in the context of ovarian cancer, mainly high-risk ovarian cancer. And I think we have to remember, you have heard from Professor Manchanda how important is identifying patients. And now we also know that for the majority of our patients, the best option still remain, in the case of ovarian cancer, the removal of the ovaries. And we know that patients are keener to ovaries removal than mastectomy, but still now not really at the age which is suggested by the common and international guidelines. So they accept ovaries removal, but later than suggested. And this is more or less an issue, because the later you have oophorectomies, the higher is the risk of ovarian cancer. And on the other side, we know that the majority of the guidelines outside of Europe, so in this case, these are the NCCN, the American guidelines, but also the Australian guidelines, they now do not suggest anymore any kind of surveillance for those women who are not keen or not prepared for oophorectomy, because we know that this is not enough for them. And now, yes, the NICE guidelines, they suggest CA125 every 4 months according to to a specific algorithm, but they are not, the algorithm is not always clear. The right algorithm it is, but not everyone is able to use. And our guidelines, the European guidelines, still suggest to use ultrasound and CA125, but the cornerstone is ovaries removal. So we will be very pleased as doctors to suggest something else to our patients instead of surgery, and so instead of menopause and all the discomfort coming with ovaries removal. And so, of course, our oral contraception will be probably the best option, but we will see if it is the option or if we have to consider in some cases and not in others. I thought that probably before explaining what we can expect from oral contraception, is important to understand which may be the etiologic factors for ovarian cancer, mainly high-grade serous ovarian cancer, which is the one related with the BRCA mutation and with the other mutations you have heard from Professor Manchanda. And you see from this slide that there are several factors, but the first is ovulation. So especially what we call incessant ovulation. So a lot of ovulatory cycles may induce inclusion cyst formation or the increase of follicular fluid. Then we can have the production of transferrin, the inflammation, DNA oxidative errors, and so we can have the onset of ovarian cancer. This is more or less what happened. And we can counteract the ovulation in several mechanisms. some of which are natural, like parity and breastfeeding, and other, like oral contraception, may counteract the ovulation with the use of specific drugs. And when we use oral contraception, we inhibit the ovulation. So we decrease the level of gonadotropins, estradiol, we increase the progesterone, and also we lower androgen level. And all these aspects all together may help in inducing some pro-apoptotic and anti-proliferative effects. And also we can reduce the ovulation-related inflammation. So this is more or less how oral contraception may work. So when we consider how we can inhibit ovulation, we also have to remember how ovulatory cycles work. And we have to consider that normally we have the start of menses at 12 years, and normally there is the natural menopause at 51 years. And so we have to consider that each woman should have 39 years of regular ovulatory cycles, which means more or less between 450 and 500 ovulatory cycles. So if we consider that, it is important to see if we can really lower the risk of ovarian cancer by lowering the number of ovulatory cycles. And this is what has been shown by this paper several years ago. And here you see that the lower the number of the cycles, the higher the prevention of ovarian cancer. And so there was a decrease of ovarian cancer by more than 40 and 50%. And so the hypothesis that the lower the cycles, so the inhibition of ovulation may decrease the risk of ovarian cancer was true. It is possible also to see the same in the general population. So not only those with an higher risk of ovarian cancer, so the BRCA carriers, but also the people without any kind of specific mutation. And this was shown in this meta-analysis. The meta-analysis is what we consider the highest level of research, because many studies are analyzed together and we arrive at some conclusion. In this case, the conclusion was that by using oral contraception, we can reduce the risk of ovarian cancer in the general population by 27%, so it's quite high. If we move to the high-risk population, we have an even greater reduction of ovarian cancer. And this was seen in this other meta-analysis, which is quite recent, so last year. And we see a reduction of ovarian cancer by 38 to 51% according to the specific statistical analysis that we can consider. And so overall, we can be quite sure that there is a reduction of ovarian cancer, even greater, in the high-risk population. We also learned that it is important for how long you take the pills. And so at the beginning, we thought that probably 3 or 5 years were enough to have a reduction, 5 years of pills were enough to see a reduction of ovarian cancer in BRCA2 and BRCA1 carriers. But in the modern times, we consider that we need to take the pills for a longer time, 10 years for the BRCA1 carriers or 5 to 9 years for the BRCA2 carriers, before we can see the benefit in terms of ovarian cancer risk reduction. And also we have learned in the most recent literature that this reduction of ovarian cancer still persists even after 15 years after discontinuation of taking pills. So it's something that requires some years, but it will remain for a longer time. And this is quite important. So the question may be why we don't prescribe massively pills, so oral contraception, to our patients. Because there are some limits and some drawbacks. And everyone knows that there are some side effects that come with drugs, regardless of the type of drugs. And also, on the other side, we're speaking about high-risk patients, not only of developing ovarian cancer, but also breast cancer. And so we have to consider these aspects both. With regard to side effects, you know, and not just as a patients, but also maybe as women and maybe with your daughter, and that there are some side effects with pills, and Some are quite common, like nausea, headache, maybe weight gain, and some others, like thromboembolism, are less common, but of course they are the most fearful side effects with regard to pills. And so we have to consider the side effect in each patient, regardless of the risk of ovarian cancer. But I think that this is not enough. This is not the main issue that we consider when we decide or not to prescribe pills to patients with the idea of ovarian cancer prevention. The most worrying side effect is, of course, breast cancer. And again, from this meta-analysis, in which we collect a lot of studies together, we unfortunately knew that there is an increased risk of breast cancer in BRCA1 or 2 carriers when they use for a long time oral contraception. And so this was the first warning we had. And so probably when we come to the decision to prescribe or not pill to our patient, we have to consider several factors together. And so from one side, we have to consider that, of course, we will have a decrease of ovarian cancer, but this will not outweigh the risk of breast cancer. So we should try to be on balance. We also have to consider the age of the patient we are in front of, because, of course, if we are speaking of a very young patient, probably the risk of ovarian cancer will be quite low, but also the risk of breast cancer will start year by year. But it will be very high when the patient is in her 50. So probably according to the age, we have to tailor our decision. And also we have to consider that according to the age, the patient will be more keen or not to undergo oophorectomy, so ovarian removal, or mastectomy. So we try to consider all this information all together. And so the guidelines are not really clear on that. I have to thank once again Professor Manchanda of sharing with us the NICE guidelines, because probably the NICE guidelines from last week are the ones with a more clear vision. So they really suggest to consider the patient and to counsel the patients according to the age, to the several factors, but also according to the possibility of going for risk reduction surgery. Of course, in a 20-year-old patient would be not possible to propose a risk reduction surgery. This is easier to be proposed in a later age. So we really need to be on balance with all the information we have with the patient. Now we can also consider another type of contraception, which is not oral, but with intrauterine device. And you know that we have two types of intrauterine device: non-hormonal, which are the oldest, and hormonal medicated intrauterine device. So most of the cases medicated with progesterone. What we know is that with a intrauterine device, we can have an inflammation inside the uterus and then moving to the ovaries, and this may lower the risk of ovarian cancer. And it was the hypothesis, and the hypothesis was confirmed in the literature, once again in a collection of several studies. And you see that if we use the intrauterine device, regardless of the type, so regardless if they were medicated or not, we can have a 32% reduction of the onset of ovarian cancer, in this case, speaking about the overall population. And also, there were some other evidences according to which if we use the intrauterine device, in this case medicated with progesterone, we have again a decrease of ovarian cancer by 47%, and apparently, at least in this analysis, without the increase of a significant increase of the risk of breast cancer. And this was true in the overall population. If we move in the specific population with high risk, because BRCA carriers, we will see that there is a decrease of ovarian cancer, so there is a benefit, but it was not really significant. So we need more research on that to be sure that in the high-risk population it's meaningful to use intrauterine device, both medicated or not. The bad news is that if we collect all the data together and if we focus on the medicated intrauterine device, there may be an increase on breast cancer. But once again, literature is not very large, so we need to do some more research on that, because of course it would be a good option for patients, also because it's more manageable compared with oral pills to be taken. And the increase is reported to be like 60%, so it's not very low. So according to the international guidelines, there is no specific recommendation regarding the use of intrauterine device. And so at the moment, we do not prescribe to our patient. Finally, we will be happy to prescribe non-hormonal chemoprevention to our patient. And on the top, most part of the literature is about aspirin, which is quite common in oncology. And recently, we can consider aspirin for some prevention, for some cancer prevention, including colorectal cancer, and also there are some suggestion in Lynch syndrome patient. But with regard to ovarian cancer, in the overall population, in this case, we have some evidences of reduction. And so we know that there is a reduction of 11%, but with the daily use, we can increase the ovarian cancer risk in the general population by 20%, or even by 34% if we use a low-dose aspirin. And the most recent analysis that we had suggests a reduction in the overall population by 30% of ovarian cancer, also of high-grade serous ovarian cancer. So there is some suggestion on that. If we speak about high-risk population, so BRCA carriers, according to the NICE, we have no clear idea that we can use aspirin to reduce ovarian cancer. So we are still in the phase in which we should do some researches on that to clear this issue. So it's something that may be a rule in the overall population, but not in the high-risk population. Nonetheless, we are studying the high-risk population. And you know that we consider the STIC, so the serous tubal intraepithelial carcinoma, as a precursor lesion of high-grade serous ovarian cancer, and we consider this to be related with the BRCA mutation. And BRCA carriers there is an incidence of STIC in BRCA carriers undergoing removal of the ovaries as high as 7%, so it's quite common in this patient. And so there is a research on that. And so what researchers are trying to understand is that the use of aspirin in BRCA carriers for at least 6 months, the removal of the ovaries may really prevent ovarian cancer, and so may reduce the occurrence of STIC or ovarian occult in the specimen in the patient that undergo bilateral salpingo-oophorectomy. And this research is ongoing in this time. Finally, another drug that is very familiar for BRCA patients, especially for those who develop ovarian cancer, are the PARP inhibitors. You know that these drugs are very helpful in fighting ovarian cancer, especially in BRCA carriers, but not limited to them. And there were at the beginning some suggestion that these drugs may help also in reducing the occurrence of ovarian cancer, also breast cancer in preclinical model. And so at the beginning, we thought that probably it may be interesting to use these drugs with this aim. Some suggestion also arrived from the clinic. This is the Olympia trial, in which breast cancer patients, most of them still with the ovaries, were treated with placebo or with a PARP inhibitor. And what we found is that in this population of BRCA carriers using PARP inhibitors and still with the ovaries, in the case in which they really use PARP inhibitors, there was a lower number of patients developing ovarian cancer during the years compared with patients under placebo. So this was a suggestion that probably PARP inhibitors may help in preventing ovarian cancer in high-risk population. There is the possibility to research on that, and there was the proposal of a study which is called Preventer study by an Australian group. There is still discussion on that. I spoke with the PI several weeks ago, and they are still discussing on that because it's not easy to be designed such a kind of trial, because we need also the pharmaceutics with us, and also it's quite expensive, but they are working on that. On the other side, we have to be quite careful about possible side effects of PARP inhibitor in healthy patients, because they are not patient with disease, but healthy patient. And we know that there may be some teratogenic issues, because there may be some loss of pregnancy in patients using PARP, and this is what we found from the preclinical analysis. But also we are aware about side effects of PARP inhibitors in patients taking these drugs for fighting ovarian cancer. You know that some side effects, especially hematological side effects, are quite common, as well as the risk of occurrence of myelodysplastic disease. So, of course, before going for this kind of research, we have to be quite sure about which kind of patients should be enrolled in this kind of trial. But I'm quite convinced that we will come with something on that in the next future. So our conclusion is that, of course, there is some option and some good option of prevention, which at the moment may be most helpful for the overall population, while for the high risk, we have to be really careful about the balance between the benefit and the risk, especially considering the risk of breast cancer. I hope that with regard to aspirin, we will have some positive data in the future, especially from the study I show you. And we will wait about the use of PARP inhibitors in this setting. Thank you.
Thank you very much. That was a very, very interesting presentation. It's so nice to see that there's so much going on about prevention. I think all of us realize that there's much more than we expected. Are there any questions in the chat?
Well, Birthe, maybe we can ask to our attendees about the oral contraceptives. In my country, the general surgeons look for breasts. They don't know anything about the hormones, estrogen, progesterone, menopause.
Mm-hmm.
But they always, say oral contraceptive equals to breast cancer. Oral contraceptive equals to breast cancer. And unfortunately, in my population, our patients really are afraid. However, this is something ENAGAGE should really focus in different countries, starting maybe from Turkey, that oral contraceptives, breast cancer risk increase is very, very low compared to the preventive effects to a more lethal cancer, ovarian cancer, I mean. Even you can use in BRCA-positive patients, as Claudia underlined. I mean, I don't know, but I just wanted to understand this point that we have to show that oral contraceptives have cancer preventive issues, which especially for ovarian cancer, and a very tiny breast cancer risk increase, which is not absolutely clear, should not be something that's preventing our patients from use of oral contraceptives. What do you think?
Yes.
As a patient? I mean,
Yes. Yes, I think that we should consider several options. And if we have maybe a young lady who desires oral contraception and she is in her 30s, for instance, probably, or maybe younger, I think it would be a good option. And also data suggests that the longer the use, the greatest is the benefit in terms of ovarian cancer prevention. So if she's young, it could be good. If she's older, maybe if she's in the age in which risk reducing surgery may be the best option. So after 35 years for the BRCA1 carrier, or maybe 40 for a BRCA2, probably is not the best option. Also because you have to take longer before you see the benefit. And so in that case, it will be too long at that point. So probably there are different cases, and I think it's our duty to stay really in the specific of each patient, of each lady we meet. Exactly.
Complicated issue. I think you need to personalize the decision.
Exactly.
And need to weigh up if there are other options of contraception. If you're using it for contraception, then that maybe have a better risk profile. On the other hand, you might get an unwanted pregnancy, which has its consequences. So the contraceptive pill is not a contraindication, I think, in BRCA carriers. But if you take it at a younger age, in your teens or 20s, then the absolute risk of breast cancer is low. Once you are 30, it's not a small risk of breast cancer. So you need to weigh that consequence. If you take it for 5 years, you approximately half your risk for ovarian cancer. But if that patient is going to have preventive surgery, then
Yes.
there's no benefit from the contraception because she's going to have preventive surgery, even if it's later. So it's not straightforward. It needs to be personalized, and it's a complex decision. You need to consider all the factors and help the patient make a right decision for herself. That's my view.
Yes, I think it's more or less the same, yes, with the HRT, with hormonal treatment for the menopause. We normally suggest patients to have after a removal of ovaries, but of course you have to tailor, and also maybe not to go too long after the age of supposed menopause as suggested by the guidelines. So probably it's really an issue of tailoring, not just guidelines, but tailoring guidelines to each patient. But I have to say that NICE guidelines have done something really helpful, I think. At the moment, they seems to be the more personalized guidelines. So probably we should consider in our everyday clinic.
Exactly.
This is what we take from here, personalized guidelines for the individual patient.
It has to be personalized, whether it's surgery or management or medical prevention should be personalized.
Yes.
Look at the evidence review in the NICE guideline. Each topic runs into about 200 pages of work. It's all freely accessible. It's very comprehensive.
Yes.
With the like 6 systematic.
Like a textbook, Ranjit. We are so proud of you, really. 200 pages for each topic. This is unbelievable.
Yes.
Yes.
Big congratulations. And Birthe, I think all is clear for our patients.
Yes.
Important, I think, to underline the role of oral contraception, IUDs, and even aspirin. I also wonder the future of PARP inhibitors in that respect, really.
And that sounded to me like something we have to be very, very careful with. There were some side effects there that I didn't really like.
I think just to be very careful of PARP inhibitors. If 2% are going to get AML, I don't want to kill 2% of people just to prevent cancer. Yeah,
No.
I'm not. No. The other thing is we don't know how PARP inhibitor is going to work. We don't know the dose. We don't know how often to give it. We don't know. I do not think that enough clinical data to support the design of a prevention trial for ovary with PARP at the moment.
Yes. I think the reason why there's still discussion on it, because it was planned.
The UK.
Yes, also in Australia, it was planned more than 1 year ago, but then it's not not for enrollment. So it's
we don't feel there is enough evidence at the moment to support a well-designed trial. So, what dose will you give it? How will you give it? You give preventive drug which is going to kill 1 to 2% of people because of AML.
Yeah, no, we can't do that. Not yet.
Okay, Birthe, we have lost half an hour, and it's our pleasure now, I think, to invite Eric from France. Dear our patients, Eric is very famous for his surgical trials on prevention issues. Let's see, Eric, are you with us? Yes. Yeah, you are muted, Eric. Eric is also an ESGO council member, one of the ESGO founders, actually. I had the chance to meet him many years ago. And also, he is a very good guitar player. Hello, Eric.
Can you hear me, Murat?
Yeah, I feel like you can play guitar to our patients, really.
Thank you very much for this presentation. I'm happy to learn that you enjoy music too. So my topic today, first of all, I would like to thank the ENAGAGE, and I feel very honored to be invited to this session to discuss about the surgical aspects of ovarian cancer prophylaxis. A lot of important things have already been said, so I won't insist on the most important of them. First of all, the cancer, ovarian cancer, is rare in general population, one lady over 70. Most of the subtypes are, unfortunately, of high grade. Considering the BRCA1 or 2 mutation carriers, the risk is much higher, with 20%, 40% lifetime risk of developing a high-grade serous ovarian cancer. And this is less for the other homolog recombination deficient genes, such BRIP1, RAT51, and so on, already discussed. In case of a Lynch syndrome, the risk of developing a cancer, which is pretty different than for BRCA1, is 10%. We must be aware that high-grade serous cancer is found most of the time at an advanced stage 3, stage 4, 75%, and the 5-year survival, in spite of development of chemotherapy and of surgery as well, doesn't exceed 45%, because we have no efficient, for the general population, an efficient screening so far. So the risk-reducing salpingo-oophorectomy is from the year 90s and 2000s, the standard, worldwide standard of prophylaxis. At the beginning, we thought that removing the ovaries was enough, but unfortunately, there was a lot of morbidity of the fallopian tube, cyst, torsion, necrosis, and this procedure was not sufficiently preventive, prophylactic against ovarian cancer. So the risk-reducing salpingo-oophorectomy became rapidly the standard. It's proposed for the high-risk ladies between age 35 to 40 if they are mutated BRCA1, a little bit later for the BRCA2, or according to the family history. For instance, if a patient has developed a tumor very young, so her daughter, she will be suggested to remove her ovaries 10 years before the youngest case. This procedure is considered as well for other homolog recombination gene mutations, and in Lynch syndrome from 40 years old around, except in PMS2 mutated patient because the risk is too low. This procedure is very efficient, as demonstrated in the big series. It reduces the risk of ovarian cancer by 90 to 95%. There is a residual risk of 5% of primary peritoneal carcinoma, high-grade serous. Similarly, this procedure reduced the breast cancer risk by 50%, but it's controversial today. And this is confirmed by further reports. But unfortunately, risk-reducing salpingo-oophorectomy carries a significant adverse effect, as demonstrated especially in the Nurse Health study, because the range of age is the same for a mutated patient, and the follow-up is long enough. Unfortunately, if the procedure protects efficiently against ovarian cancer, it carries a risk of pulmonary cancer, because at that time the women were heavy smokers. It carries a significant risk of coronary heart disease and a stroke. And the total mortality was increased because of hormonal privation. And so that's why 1/3 of high-risk ladies carrying this mutation refuse or delay the RRESO in the world. And this tendency is stable, or even it increased with time, as demonstrated recently. So what to do for this patient to refuse the risk-reduction surgery? Maybe we could propose a new pathological-based two-step prophylaxis. Because we have a better knowledge of the origin of ovarian cancer, thanks to a better pathological examination of RRESO specimens and development of ovarian cancer in the context of endometriosis. Globally, there are two types of cancer due to two ways of development. The first one considers a tumor coming from the tube, through the tube, that carries retrograde menstruation and possibly abnormal cells from the uterus. And this kind of dissemination is at the origin of endometrial cancer or clear cell carcinoma. These are low-grade tumors with a slow development, and the incidence is unfortunately low in the general population, only 15%. And for people carrying endometriosis, the risk of developing a cancer is 3%, which is much higher than the general population. On the opposite side, there is other type of tumor, the high-grade tumor or type 2 tumors that's developed from cells within the tube, and especially at the end of the tube, at the fembrral end of the tube. It concerns ladies with genetic deficiencies, such as a BRCA1 mutated patient of homolog recombination gene patient, and this tumor is generally affects 100% of these ladies. But in the general population, we see 80% of them affected by the high-grade tumors as well. And the precursor of the lesion is located not in the ovary or in the tube, but it's located in the fallopian tube, at the end of the fallopian tube. It is called the STIC, serous tubal intraepithelial carcinoma. So the question is why bilateral salpingectomy couldn't be a temporary bridge to risk-reducing bilateral oophorectomy? Because it offers several advantages. It's better than nothing for ladies reluctant to undergo risk-reducing salpingo-oophorectomy. It protects against both types of ovarian cancer, type 1 and type 2 at the same time. But it preserving the ovaries, it preserves the femininity and possibly fertility. But this concept has some inconveniences. Is prophylaxis against high-grade serous similar to RSO? How to surveil this patient? Does it protect against breast cancer? And what about the secondary oophorectomy? So that's why a prospective study was necessary to test the prophylactic efficacy of this policy. And we were very interested in this work, and we started in 2012 a phase 1/2 study in high-risk lady who refused the RRSO that was suggested first. So we suggested to perform a radical fembryectomy, which consists of the removal of the whole tube and the little part of the tube tethered to the ovary, with a delayed oophorectomy at the age of menopause. So 121 patients entered this study. The morbidity of the procedure performed mainly by laparoscopy, both fembryectomy and oophorectomy had no serious complication. The pathological results, we found out two problems of the fallopian tube, one occult high-grade serous carcinoma, and one isolated serous intraepithelial carcinoma. Both were managed according to guidelines, but no problem on the ovarian fragment attached to the tube. For the delayed oophorectomy performed at the age of menopause, we never observed any abnormalities. And during the surveillance of these patients, we observed 21 breast cancer, but only 3 de novo breast carcinomas, always triple negative. Considering the primary endpoint with 10 years follow-up right now, we published the paper last year, but we reviewed the series in January. We observed 1 abdominal wall intramuscular carcinoma, serous-like. We can explain this result because this patient had no abnormality, nor on the fembryectomy, nor on the secondary oophorectomy. We observe as well 1 pancreatic carcinoma and 1 cervical lesion. So with this, with this technique, we had observed much less ovarian carcinoma than expected in this high-risk population. That's why we consider it has a relative prophylactic effectiveness. And we had one good surprise. Thanks to this procedure, 1 patient could deliver twins after assisted reproduction technology. So maybe there is a new hope for the BRCA mutation carriers is to offer for these patients, very aware of the disease, a free choice between RRSO or RSDO. That means it was already tested in the TUBA WIST-1 that demonstrates that the two-step prophylaxis has a significant improvement in quality of life. But considering the efficacy, we need a larger, a bigger sample and a longer follow-up to consider the non-inferiority of this policy compared to the standard risk-reducing salpingo oophorectomy. And this is the goal of the TUBA WISP-2 Dutch study that is open. And in France, we opened as well a second trial, which is called fembryectomy, because it's a French word, which is exactly the same design, except that the secondary oophorectomy is not performed at 40 years old, but is performed at the age of menopause. And to finish, I will talk some words about the opportunistic salpingectomy. Since the fallopian tube is a pivotal role in the development of ovarian cancer, maybe we can prevent even in the general population the development of this cancer by performing bilateral salpingectomy without oophorectomy in patients candidate for a benign hysterectomy, for instance, or any other abdominal surgery. And it has been tested, it has been assessed in Canada, and they observed that this policy with more than 50,000 individuals with salpingectomy and those with complete oophorectomy, they did not observe an excess in ovarian cancer in the group of salpingectomy alone. That's why this procedure protects against not only with high-grade to high-grade serous, but also non-high-grade serous carcinomas. So to conclude, there are three messages. The first one is this two-step prophylaxis seems safe and efficient and maintain the femininity and possibly fertility. But this alternative can be suggested for high-risk women who are reluctant to standard RSO, but only in the frame of a controlled survey, because it needs a special examination of the tube. There is a CFIM procedure. And concerning the general population, we have to promote the opportunity salpingectomy because it has quite no morbidity, only for patients who have no desire of pregnancy, no morbidity, and it carries an effective reduction in type 1 and 2 ovarian and tubal carcinoma, and possibly in peritoneal carcinoma. I thank you very much for your attention.
Wow. Thank you, Eric. I think this was so inspiring for our patients. I am sure they did not hear, probably they heard about salpingo oophorectomy, but it was first for them to hear about delayed oophorectomy, so salpingectomy with delayed oophorectomy, or opportunistic salpingectomy, which means that you go for any type of surgery, whatever it is, and during that surgery, you ask for your doctors to remove both tubes, which has also conservative effect for ovarian carcinoma. Birthe, as a patient, ovarian cancer patient.
I have a comment here, because I hear from some women that they don't want to get rid of their ovaries because they think that the ovaries provide hormones the whole life. And I would like your opinion. And I think that is why they prefer to have the salpingectomy instead, and then maybe later on have the ovaries removed. But that is what I've heard from them as their concern. And I would like to have your comment on that.
Yeah. The concerns about that, especially centered on the real prophylaxis against ovarian cancer, and so that's why the first results of this preliminary study are promising, but it needs a larger sample and a longer follow-up to confirm. That's why the WISP or the fembryectomy trials, or even the SOROC, is another one with the same design, are very important to enter. And this study should have stopping rules. That means you have to follow the patient for a long time. And if you observe an excess in ovarian cancer, that's what we did in our series. We have to stop the series and to reoperate early the patient for the ovary. But
Yes.
in our series, we didn't observe any abnormality in the ovaries. And even for the patient with the castration at the time of menopause, we didn't observe anything as well. And my conviction is that this type of cancer is mainly due to the tube. Mainly, I don't say exclusively, mainly due to the tube, and that the removal of the ovaries is not so important, in fact, but it's a feeling.
And yeah, because they think the hormones are
The second one is the breast cancer, which is very important because there are controversial data on that. The mathematician says that in fact the protective effect of rectomy on breast cancer is not so clear, finally, and but it's a mathematician statement. So we have to be very careful on that, and probably the best candidates for this choice should be the patient with a prophylactic mastectomy, because there is no other issue. They can retain their ovaries.
To answer Birthe's question specifically, I think most of the estrogen production in the postmenopausal occurs through peripheral metabolization of androgens. So not necessarily from the ovaries, Birthe. It's mainly the androgens and the adrenals in the body that are producing hormones that get metabolized in the peripheral fat that produce estrone, essentially provide estrogen in a postmenopausal patient. So it's not, I think ovarian function is very, very limited or very negligible once you hit menopause. So it's just to reassure that removing the ovaries after the menopause wouldn't necessarily impact your long-term health.
Okay. Thank you. It's just I'm just saying what I've heard patients say, and it's very good to hear your opinion about. Thank you. Are there any questions in the chat?
Birthe, I mean, our patients are really very interestingly, with good numbers, are listening us. I sometimes, breast cancer patients do come us, but some medical oncologists really forget them to send us for gynecological examination annually, or I would suggest, if they have a possibility, to make a genetic testing, but sometimes they cannot afford it. Every month, I see one patient who had previous breast cancer, but come with advanced level ovarian cancer when she is 60. So I will suggest from this point to our patients that if you or your friends or your members in your local societies have breast cancer, that will be the best to go to a genetic testing. Please don't forget this. If you cannot afford this test, you can go to annual examinations, and if possible, you can even suggest some sorts of prophylactic surgeries, even if you cannot make it. I mean, I then feel a little bit sorry for those patients when I see that they have never heard about BRCA testing, they never heard about familiar breast ovarian cancer syndrome. Definitely, they are living in the postmenopausal period. They are breast cancer survivors and are not aware of risk of ovarian cancer expecting for them.
I think that we have had a lot of information today. So a lot of patients that are from different countries, and they can bring all this information along. I think it's been very, very beneficial and very informative for all of us.
Yes, and now again, Jurgen Pierre from Netherlands, like Claudia, will lead a project in the prevention committee, a statement on opportunistic self-injectome. I mean, you are not a breast cancer, you don't have anything about BRCA, but you go to cesarean section, you go to myomectomy, you go to some sorts of surgeries. That should be an ESGO and ENAGAGE statement, and the patients should know that removal of the tubes is better than just simple tubal ligation. That should be another policy for us to offer for our patients. I mean, even if you are not risky, I mean, it's better to make self-injectomy compared to tubal ligation. We will work all together. I think these papers will be ready by 2025. We will make again webinars on that, statements and flyers on that. Okay, Birthe, thanks to all our speakers, I think.
Yeah,
They were
thank you so much, everybody. It was very, very useful. We enjoyed it. I'm sure all the audience, we had many patients listening. I'm sure they all enjoyed it. Thank you
We are
so
so
much.
honored. We are so honored to have you.
Thank
You
you.
saved your time for us. All of our patients and ENAGAGE is proud of you. We will never forget your involvement and support to ENAGAGE. Thank you, my dear friends. Thank you, my dear Queen Birthe. Hoping to see you very soon. Oh,
See you
Thank
soon.
you. Bye-bye. Thank
bye
you.
bye.
Thank you. Thank you.
Thank you so much.
Bye.
Bye. Thank you to all of
Thank you. Bye-bye.
Have a nice evening. Bye.
Bye.
Thank you.
Bye.
Eva, is recording finished? Ah, okay. Eva.